Hello, this disorder of the potassium metabolism presented by the SchrDbb reference Chemical Pathology Lecture Notes of University of Cape Town by George Van der Waart et.al. So here we're going to visualize the disorder of the potassium metabolism. But before we begin, we are going to start with potassium metabolism. You need to know that in contrast to sodium, which is more in the extracellular fluid, potassium here is going to be more in the intracellular fluid. Is it clear? So generally, you have already found the volume of the extracellular fluid and intracellular fluid. They say that generally, if you have a 42, a patient with 70 kilograms, there is 60% of total body water. So it's going to be 42 liters. So 1/3 of that 42 is going to be extracellular fluid, while 2/3 is going to be intracellular fluid. So if you do 2/3 of 42 liters, you're going to have a value that is going to be close to 28. Is it clear? So that is the case here, because 42 is going to, we are going to have a value which is close to 28. Now the concentration of potassium ion in millimoles per liter or milliequivalent per liter in the intracellular fluid is going to be very high. That's 150 milliequivalent per liter or millimole per liter, and in the extracellular fluid is going to be low. Is it clear? So it's 30 times higher from the intercellular to extracellular fluid, and the potassium ion content is 98% with respect to that. And I've forgotten, sorry, we started the tutorial before without presenting the professor that was involved with this tutorial. That is Dr. Peter Behrman and Prof. Eric. So we continue with this tutorial by explaining the fact that we are going to explain the fact that the plasma potassium ion level is going to be highly maintained. So the plasma potassium ion level is going to also is going to be a reflection of the whole body potassium ion status. Is it clear? Like in the case of diabetic acidosis, where you're going to have accumulated hydrogen ion that is going to force the potassium ion out of the cell. As I've initially told you, every time we have hydrogen ion in the circulation, potassium ion is going to be forced out of is going to be forced also into the circulation. Every time you see an acidosis, potassium ion is going to follow, hyperkalemia is going to follow, except there is a hormone that's going to counteract the effect. Is it clear? So those are the different cases you need to know. Now you need to know that they are going to, why the intracellular potassium ion is going to be very, very high. There are different mechanisms. The first mechanism which is involved with making the intracellular potassium ion to be high is the sodium ion and potassium ion pump ATPase. Is it clear? So it's going to always take 3 sodium ion outside the cell and take 2 potassium ion inside the cell. Is it clear? So that's why it's going to maintain the potassium ion to be very high inside the cell. And also you need to know that the intracellular anion consisting of the organic phosphate in various forms, that's creatinine phosphate, the ATP, the phosphorylated glycolytic intermediate, as well as protein are going to bind more to potassium than sodium. So they bind to this cation of potassium. That's the second reason why potassium is going to be very high in the intracellular cell. Now, we need to know potassium ion and the cell membrane potential. You need to know that there are certain cells that have a membrane potential. Is it clear? And now, the question that I'm going to ask you is, why is it that it is only potassium ion that is making that we are calculating the membrane potential from? Is it clear? We are calculating the membrane potential from potassium just because potassium is the only ion that is permeable. We calculate the resting membrane potential of a cell from potassium because potassium generally in excitable cell is the only ion which is permeable through the membrane at rest. Is it clear? So when you are at the rest, when an excitable cell such as a neuron or a cardiac cell is at rest, the only ion that is permeable to that membrane is going to be that of potassium ion. Is it clear? And since it is the only one which is permeable to the membrane, we are going to calculate the resting membrane potential from the ion which is only permeable to the membrane. Is it clear? Now, to calculate the resting membrane potential, use the Nernst equation, and generally the Nernst equation is given as negative RT all over NF ln of the Kc of the ln of the product, the concentration of the product raised to the appropriate powers, divided by the concentration of the reactants. So that's generally the formula of the Nernst equation. Generally that's that. But now we need to know that R is the molar gas equation, T is the temperature in kelvins, F is the Faraday. When you put that and then you remove the ln, generally you are going to have negative 0.09, negative 0.059 divided by n log of the concentration of the product all over the concentration of the reactants. Is it clear? So when you do that now in a case of a cell, and Nernst equation in the case of a cell, you are going to have negative negative 60 log of potassium ion concentration all over the potassium concentration inside all over potassium ion concentration outside. So it's negative 60. Generally, if you do all that, you're going to have negative 60 log of potassium concentration inside all over potassium concentration outside. Is it clear? But you need to know that potassium concentration inside was given as 150, outside was given as 5. So when you do 150 divided by 5, you have 30, and when you calculate, you're going to have negative 90 millivolts. That's why the resting membrane potential is always negative 90 millivolts. Is it clear? So that is the reason. Now, the next thing you have to know that what you are also capable of calculating the membrane potential when the cell is active. Is it clear? You know that you need to know that what in a case of a depolarization, the sodium ion is the one that is going to enter the cell. Is it clear? That's why in depolarization, when the sodium ion enters the cell, you have a change in membrane potential. Is it clear? Since sodium ion is the one that is which is permeable to the membrane during depolarization, the best ion that is used in order to calculate the membrane potential when there is depolarization, the best ion used is going to be sodium ion. Is it clear? So in that case, when you want to calculate the membrane potential during depolarization, we are going to use negative 60 log of sodium ion concentration inside divided by sodium ion concentration outside. Is it clear? To calculate that of the case of that one. Now the next again for repolarization, since repolarization potassium is the only one which is permeable, you are going to calculate still with this formula. Now in case of cardiac cells, you need to know that there is depolarization. There is first the primary repolarization and there is the plateau phase. In the plateau phase, you need to know that what there is the calcium ion, which is the calcium ion is the main one which is permeable to the membrane. So in the plateau phase, in order for you to calculate the resting membrane potential, you can use the calcium ion, and generally you have to know that calcium ion inside and the calcium ion outside is going to be equal at the level of the plateau phase. Is it clear? That's why the plateau phase is just a straight line, because calcium ion inside is equal to outside. The same number of calcium ion which is exchanged is going to be exchanged with the same number of potassium ion. So that's why you're going to have a plateau phase at the level of the cardiac cells. Now let's visualize different cases with cell membrane potential. In a case where you have a hypokalemia, is it clear? When you have hypokalemia, it's going to enhance the potassium ion efflux. So immediately you have a patient that has hypokalemia. Potassium is going to move based on the concentration gradient from the intracellular free to the extracellular free. Is it clear? And when there is movement from intracellular free to extracellular free, you see that what is going to increase the potassium ion outside and reduce the potassium ion inside, making this ratio to do how to reduce. Is it clear? So if you have an increase in so when there is efflux, meaning that what the potassium ion so you're going to have when the potassium ion is going to efflux outside, it's going to cause a hyperpolarization state. That is one way of visualizing it. Is it clear? So on your diagram of action potential, when you have a hyperpolarization state, that's is because of that efflux, excessive efflux of the potassium ion. Also, another way to visualize is that what, when there is hypokalemia, it means that what, it means that the potassium ion in the extracellular fluid is going to be low as compared to the potassium ion in the intracellular fluid. Is it clear? Since the potassium ion is very low compared to intracellular fluid, you see that what, it's going to be 150 divided by a very low value. Generally, when you do the division, you're going to have 60 as a ratio. That's why when you do the negative 60 log of 60, you're going to have a value of negative 107 millivolts. And that negative 107 millivolts now is going to be the new resting membrane potential. Is it clear? So this is going to be the new resting membrane potential. And generally, if you have this very low new resting membrane potential, is going to be difficult to excite excitable cells. Is it clear? So the neuron is going to be difficult to be excited. So in the case of hypokalemia, you have a state of a pseudo paralysis. So the nerves are difficult to excite. Is it clear? In hypokalemia. So now let's go now to visualize but in the case of hypokalemia, in the case of the heart, for the heart you are going to have, since the heart is going to be difficult to be excited, you are also going to have a prolonged QT interval. Is it clear? The QT, so you are going to have a prolonged QT interval because the heart is going to be difficult to excite, because the QT interval is a time from initiation of depolarization to initiation of repolarization. Is it clear? So since you see that the QT interval here is going to be prolonged, just to tell you that what, the time for you to initiate depolarization is going to be very difficult in the case of hypokalemia. Is it clear? But now when you have a prolonged QT interval like that for a long period of time, the heart now is going to act in an opposite direction by doing what is called a ventricular tachycardia, and you have a form of ventricular tachycardia which is called torsade de pointe, where you have different polarities of the ventricle, of the phases of the tachycardia. Now the next thing is hyperkalemia. Hyperkalemia, you are going to have, so in case of hyperkalemia, you don't have efflux of the cells. Is it clear? But now it makes now that what, the potassium ion stays accumulated inside the cell. Now in this case, when there is potassium ion inside, potassium ion stay accumulated, and then there is excessive potassium ion outside the cell, what happens is that what, this ratio is going to reduce, and it makes the value now to increase in number. It makes now to become something like negative 50 millivolts. It makes something like negative 50 millivolts. But now you need to know that what, generally the threshold voltage at which there is simulation of action potential is generally negative 55 millivolts. If you are having a resting membrane potential which is above the threshold voltage for your excitation, it means that you are going to be constantly excited. Is it clear? So that's why in the case of hyperkalemia, it's going to result to excessive excitation of the cells. Is it clear? That is going to facilitate now depolarization. So here you're going to have excess depolarization, but here in hypokalemia you're going to have excess repolarization or hyperpolarization. Is it clear? But here in case of hyperkalemia, since you are the cells are always going to be excited, you're going to have excess depolarization. So that's why in this case it can result to ectopic beat or ventricular fibrillation. Now you need to know that also certain drugs such as sulfonylureas are used now to treat diabetes. How are they used to treat diabetes? So sulfonylureas are used to treat diabetes because of they specifically block potassium ion channel in pancreatic beta cells. You need to know that one. You need to know that generally you have to know that when insulin is secreted, it is going to enter the cell with when insulin is going to be when insulin is used, it causes the stimulation of the potassium ion entrance into the cell. Is it clear? So you need to know that this is how sulfonylureas act. They act by blocking the potassium ion channel in the pancreatic beta cells. Is it clear? So by inhibiting the potassium ion efflux down the concentration gradient, so potassium is not going to move outside, it's going to stay inside the cell. So this drug now decreases cell membrane polarization and then facilitate depolarization, which triggers insulin release. Is it clear? So the depolarization that occurs inside the beta cell is what is involving with the release of insulin. So here the cells here, the drugs here are just to inhibit that efflux of the cell to cause a hyper a depolarization of the cells of the beta cells to result to the release of insulin. Now the next thing also, this you need to know that in the normal physiology, when you don't use sulfonylureas, there are certain chemical components which are involved to cause that depolarization. ATP can result to potassium ion still remaining in the intracellular field, thus resulting to depolarization. Glucose also is one molecule of intracellular fluid which can result to that, and we have other forms of element. Now the next thing that you have to visualize now is a potassium ion homeostasis. Is it clear? Now you need to know that potassium ion homeostasis can occur at the level of the proximal convoluted tubules, it can occur at the loop of Henle, and it can occur at the distal convoluted tubules. So those are the three main places where it can occur. Now the first is proximal convoluted tubule. In proximal convoluted tubules, usually the potassium ion practically all is reabsorbed in the proximal convoluted tubules, practically all the potassium ion. So you need to know that potassium ion is going to be filtered, and practically filtered potassium ion is going to be practically all reabsorbed at the level of the proximal convoluted tubules and the loop of Henle. Is it clear? Now the net potassium excretion is going to depend on the secretion of the potassium ion by the distal convoluted tubule. So if you want to secrete potassium ion, it's usually at the distal convoluted tubule, and practically all the reabsorption of potassium ion occurs here, both at this level and at this level. Is it clear? So now generally there are going to be the potassium ion channels here which are involved with the reabsorption of the potassium ion. And also we have these other channels, sodium ion channel, chloride ion channel, with the potassium ion channel, and all that are going to involve. Now there is a pump here, the sodium ion glucose importer pump, or sodium ion amino acid importer pump, and all that can be used here. And then here we have the chloride ion channel for the flow. Now at the level of the loop of Henle, the main channel that we have the sodium ion, potassium ion, 2-chloride ion channel, 2-chloride ion co-transporter. This co-transporter is going to transport all of them, and then chloride potassium is going to make sure that potassium ion can enter the circulation. Is it clear? So now you need to know that one diuretics, and this diuretic is called Lazellix or furosemide. Is it clear? Furosemide is going to act as this level to prevent the reabsorption of this ion. When these ions are not going to reabsorb, it's going to concentrate in the urine and making the fluid, it's going to concentrate the filtrate and making that water is not going to be reabsorbed. Is it clear? You need to know that normally in the countercoil multiplier mechanism, you need to reabsorb this molecule for water to be absorbed into the circulation. But if this molecule are not reabsorbed, it means that there is no countercoil multiplier mechanism, and which makes sure that what fluid is going to be lost in the urine. That is the action of the furosemide, or in brand name Lazellix. Now we need to know that the distal convoluted tubules, you need to know that what aldosterone is going to act at the level of the sodium ion channels. It only stimulates the effect of the sodium ion transporter. So the sodium ion transporter is going to be stimulated. Now when the sodium ion transporter is stimulated such that the sodium ion enter, it indirectly stimulates the basolateral site for the activation of the sodium ion ATPase. Is it clear? It indirectly stimulates here. So the first effect is that it's going to stimulate the sodium ion channel to open for sodium ion to enter, and then it's going to indirectly stimulate the sodium ion potassium ion ATPase to work out. Because since sodium ion enters excessively here, you need to know that what sodium ion is going to be excess in the cell. Since it's excess in the cell is going to try to put sodium ion in blood and put back potassium ion into the cell. And potassium ion has an outflow effect at the level of the channel here, so potassium ion is going to move out. And since potassium ion move out, it usually moves out with hydrogen ion. Is it clear? Now, how is hydrogen ion formed? We need to know that what the carbon dioxide which is present in the circulation can diffuse and enter here. So carbon dioxide bind with water to produce hydrogen ion and hydrogen carbonate ion. Hydrogen carbonate ion can be reabsorbed and hydrogen ion is going to be lost. Is it clear? So now these are the different diuretics that can be used. In the case of a spironolactone is called a potassium ion sparing diuretics. Why? Because it does not cause the release of potassium ion. Is it clear? Because it is antagonist to aldosterone. So since it's antagonist to aldosterone, you are not going to have the secretion of potassium ion in this case. The next is going to be amiloride. Amiloride is only going to inactivate the sodium ion channel, so it prevents the sodium ion from entering the cell. Since sodium ion does not enter the cell, sodium ion is going to only be present here. So amiloride can also be another potassium ion sparing diuretic. Now you have also diamox, but diamox now, because it's a diuretic that acts by causing ink, is going to, in the case of diamox now, it's going to inhibit the conversion of carbon dioxide to produce hydrogen ion and hydrogen carbonate ion. Is it clear? So you are going to have no hydrogen ion secretion into urine, so it may even prevent diuresis. So now, there are a number of factors that are going to affect the renal potassium ion excretion. Is it clear? So what are those factors? So the first one is the sodium ion delivery at the distal convoluted tubules. Is it clear? So you need to know that what potassium ion cannot be excreted at the level of the distal convoluted tubule unless there is enough sodium ion that is present. Is it clear? You need to know that what if there is excess sodium ion which is delivered at this level, is it clear? The excess sodium ion is going to enter, and the excess of it is going to activate the sodium ion ATPase. Is it clear? So more potassium is going to be released. So the more there is sodium ion which is delivered in the filtrate at the level of distal convoluted tubules, the more potassium ion is going to be excreted, and the more hydrogen ion too is going to be excreted. Is it clear? And that's the same in a contrary way. Is it clear? So you need to know that what diuretics like Lasix impair the sodium ion reabsorption at the loop of Henle, and not only the sodium ion but also this. Is it clear? We need to also know that but in the case of diuretics like amiloride is only going to impair the sodium ion reabsorption at the level of the distal convoluted tubules. Since it impairs the sodium ion reabsorption at the level of the distal convoluted tubules, it prevents excessive delivery of sodium ion at the level of distal convoluted tubules. Since there's low delivery of sodium ion at the level of distal convoluted tubules, now potassium ion now is not going to be excreted more, so potassium is going to be converted. So another form of a potassium sparing diuretic is going to be an amiloride, and the mode of action is not going to be anti-aldosterone. Is it clear? So those are the cases that you have to know. So it enhances sodium ion exchange. So when you have so when you impair the reabsorption, you enhance sodium ion exchange and potassium ion at distal convoluted tubules. So I'm not going to speak about that. The next thing is the aldosterone. So you need to know that aldosterone is going to cause the sodium to be exchanged with potassium ion and even with hydrogen ion. So it causes the activation, as I've already explained, activation of the ion channel. That is going to indirectly cause the secretion of the potassium ion and the hydrogen ion in the distal convoluted tubules. Is it clear? So that's how it acts, and there are different diseases associated there. Now you need to know that there are certain drugs which can oppose its effect, like anti-aldosterone, like spironolactone or eplerenone. Is it clear? But the side effect of spironolactone is that it can cause gynecomastia and some form of infertility, while eplerenone is not actually with those side effects. Now the next method of of controlling the excretion of potassium ion is by hydrogen ion available. Now you need to know that what, since sodium ion is reabsorbed in distal convoluted tubule in exchange with potassium ion and hydrogen ion, a reciprocal relationship will exist also between potassium ion and hydrogen ion excretion. The more the hydrogen ion is available for exchange, the less the potassium ion is going to be excreted. Is it clear? It means that what, you need to know that normally when sodium is present at the level of distal convoluted tubules, potassium ion and hydrogen are usually released. Is it clear? But if there is more hydrogen ion at the distal convoluted tubules to be released than the potassium ion is going to be conserved and more of that hydrogen ion is going to be released. Is it clear? So you have a patient who have acidosis. So if the patient has acidosis, and when the body is trying to compensate the acidosis, the body is going to compensate the acidosis by releasing the hydrogen ion but not changing the potassium ion level. Is it clear? So those acidosis predisposes to the potassium ion retention. So as I was just saying, whereas alkalosis, in alkalosis or when hydrogen ion secretion in the renal tubule is going to be impaired. So usually you have hypokalemia. So you have to know that what, if the blood is high in acid, if your blood is high in acid, it means that what you are going to, so acidosis, if you have acidosis in your blood, is it clear, it's going to try to retain the potassium ion in the circulation and cause even a form of hyperkalemia. Is it clear? But when you have alkalosis, it's going to try to do what? So the potassium is going to be excreted more than the hydrogen ion, because the hydrogen ion wants to be conserved, is trying to be conserved in the body. Is it clear? So in those type of patients who have alkalosis, they have hypokalemia. Is it clear? So whether primary problem is alkalosis, so enhancing the urinary potassium losses and potassium ion transfer into the cell, or whether the potassium ion depletion is primary prevent leading to excess of hydrogen ion excretion. So actually they are just saying that what, every time you need to know that at the level of the intracellular fluid and the level of the blood, is it clear, potassium ion usually works with the hydrogen ion. Every time in the blood and intracellular fluid, is it clear, potassium ion always work with the hydrogen ion. So every time there is a hyperkalemia, usually associated with acidosis. Is it clear? But at the level of the urination, urination, you need to know that what, the potassium ion and the hydrogen ion are seen in the opposite way. Is it clear? So if there is excess acidosis, so is going to try to retain the potassium. So potassium is going to be released more preferentially than the hydrogen inside the kidney. Is it clear? They work in the opposite way. So those are the cases involved. So now here you're going to consider the following disorder of the abnormality of the potassium and the hydrogen carbonate coexistence. Now this disorder is associated with decreased potassium ion, and this is associated with increased hydrogen carbonate. So if you have mineralocorticoid excess, is it clear, an excess in mineralocorticoid is going to cause a decrease in potassium ion, and it's also going to cause an increase in hydrogen carbonate. Mineralocorticoid excess, example, aldosterone. We already know that what aldosterone is going to cause what? It's going to cause the release of potassium ion, and also it's also going to cause indirectly the release of hydrogen ion. Is it clear? Since it causes the release of hydrogen ion, there is no hydrogen ion to bind with hydrogen carbonate for the release at the level of the lungs. So that's why hydrogen carbonate increases. Is it clear? Now the potassium ion losing diuretics. The potassium ion losing diuretics, such as furosemide, it causes the release of potassium ion. And generally, when there is a release of potassium ion, there is going to be the release of hydrogen ion. Is it clear? Potassium ion losing diuretics, and also vomiting. In case of vomiting, you need to know that what, inside your vomitus there is hydrogen ion and there is also potassium ion. They work together. Is it clear? So you need to know that they work together, hydrogen and potassium. When you are vomiting, you're going to lose them. Now, we need to know that in a case of diarrhea, So in vomiting you have potassium ion and you have hydrogen ion. But in the case of diarrhea, you need to know that what the plasma potassium ion, in diarrhea there is going to be potassium ion, but in diarrhea there is no hydrogen ion. In the diarrhea that you have, there is no hydrogen ion, there is only potassium ion. So in diarrhea there is loss of potassium ion and there is loss of hydrogen carbonate. Is it clear? You are losing potassium ion and you are using hydrogen carbonate and losing also sodium ion. Is it clear? So since you are losing also high sodium ion, that sodium ion is going to try to, the hydrogen is going to try to compensate the loss of sodium ion by staying in circulation. So in diarrhea you are going to more have even an acidosis. Is it clear? So you have a hypokalemic acidosis. In this case it is a hypokalemic alkalosis. Is it clear that you have these cases? Now when you have hypokalemic acidosis, so you have hypokalemic acidosis in the case of a diarrhea because you lose potassium ion, sodium ion and hydrogen carbonate. Is it clear? Now you have also in the case of renal tubular acidosis, you have said that the renal tubular acidosis was divided into type 2, which was affecting the proximal convoluted tubules, so and then it's divided into type 1 affecting the distal convoluted tubules. So let's take type 1. So let's know that at the level of distal convoluted tubules, normally there is going to be the secretion of the hydrogen ion at the level of the distal convoluted tubules. Is it clear? So if there is no secretion of distal convoluted tubules, is it clear? It means that it's going to result to an acidosis. Is it clear? And also if there is no so in the case of if there is no reabsorption of hydrogen carbonate at the level of the proximal convoluted tubule in the type 2, you are also going to have a renal tubular acidosis. Is it clear? So in those cases you don't reabsorb potassium ion, you don't reabsorb hydrogen carbonate ion in the case of type 2 renal tubular acidosis. So you are going to have this schematic view. Now the next one is azotazolamide. You have diversion of urine in the DIT. So all that. Now what causes now a plasma potassium ion to increase and a plasma hydrogen carbonate to increase? That's a hyperkalemic alkalosis. It's a chronic respiratory acidosis. Is it clear? So in this patient you have a chronic respiratory acidosis that has stayed for a long period of time. As I've told you, when there is acidosis for a long period of time in the body, potassium ion is going to enter into the circulation. That's why you have an increased level of the plasma potassium ion. So is it clear? So if you have a chronic acidosis, just know that potassium is going to enter into circulation. And also you need to know that it is respiratory acidosis. It means that what the hydrogen ion is going to bind to the hydrogen carbonate to cause the release of hydrogen of the carbon dioxide. Is it clear? So it's going to also increase. So when you have a chronic respiratory acidosis, hydrogen carbon is going to try to increase in order to compensate in order to regulate now the respiratory acidosis. Now when you have Addison disease, there is no aldosterone to counteract the effect. So it's just the opposite of mineralocorticoid excess. There is no aldosterone to counteract the effect, and there is excessive hydrogen ion to bind with the hydrogen carbon. So there is reduce of this. If there is potassium ion diuretics, it's also an anti-aldosteroneism. If you have acute renal failure, you can have also this. Potassium ion circulation is going to increase, and also have acidosis and all that, even ketoacidosis and all that. Now you need to know that what with these other cases, this is going to show that you have a normal anion gap. Why this shows that there is an increase anion gap. Here there is an increase in anion gap because why? In ketoacidosis, ketone bodies are going to serve as the anions. That's why the anion gap is going to increase. While in acute renal failure, you have many phosphate ion and other negative ions such as sulfate and ion, phosphate ions, hydrogen phosphate ion are going to be retained into the circulation because of the decreased glomerular filtration. That's why there's a high anion gap. But in these other ones here, there is normal anion gap. Now what is you have seen the regulation of the factors that are involved with the renal potassium ion excretion. So we are finished with that. Now let's visualize the endocrine regulation of the potassium ion homeostasis. The first involved in the endocrine regulation of potassium homeostasis is aldosterone, where it is going to cause the indirect excretion of this of potassium ion in expense of the reabsorption of sodium ion. One, it can do that at the level of the GIT. It can do that at the level of the sweat gland. Is it clear? So potassium is going to be more secreted in sweat than the sodium ion. Is it clear? So you can do that in the GIT, you can do that in the sweat gland, and you can also do that in the kidney. Is it clear? So hyperkalemia directly stimulates aldosterone. Is it clear? So we have seen that aldosterone stimulation was through the renin-angiotensin aldosterone system. Is it clear? The renin-angiotensin aldosterone system is going to be stimulated from a reduced renal perfusion. But you need to know that what immediately there is hyperkalemia. Hyperkalemia is going to stimulate the cells in the zona glomerulosa for direct secretion of aldosterone without passing through the renin-angiotensin aldosterone system. So hyperkalemia stimulates directly the aldosterone release. Now the next is insulin. So you need to know that what insulin promotes the entry of the potassium ion into the cell, just like the entry of the glucose into the cells. So immediately glucose enter the cell, potassium ion is going to enter the cell with him. Is it clear? So that is so both of them are going to enter the cell together. Is it clear? Because we said that among the reason that the recipe that potassium is high in the intracellular fluid was because there was glycosylic substances inside the cell. So that's why when glucose is entering the cell, it's attracting potassium with it into the cells. Now the next one is catecholamines. Now you need to know that what catecholamine is going to enhance. Catecholamines such as adrenaline or noradrenaline, epinephrine and norepinephrine are going to enhance the potassium uptake into the cells. Is it clear? By stimulating glycogenolysis. Is it clear? So catecholamines is going to enhance the uptake of potassium into the cell by stimulating glycogenolysis, the breakdown of glycogen. So it means that what? So how does catecholamines actually cause the entry of potassium? The effect of entry of potassium is going to be an indirect effect, because the cells here is going to cause glycogenolysis. Since it causes glycogenolysis, you're going to have what? You're going to have phosphorylated sugars, and you have other forms of sugar that are going to attract potassium into the cell. Is it clear? So when potassium is going to be attracted into the cell, you are now going to have a reduced potassium ion outside the cell. Is it clear? So that this is the effect. So this effect is going to be exploited by using beta-adrenergic drug to treat hyperkalemia. You can use beta-adrenergic drug, and those beta-adrenergic drugs are typical catecholamines. Is it clear? So you can use, when you want to treat hyperkalemia, just use your beta-adrenergic drug, because it's going to reduce the potassium ion outside the circulation by causing what? By causing glycogenolysis. When there's glycogenolysis, there's going to be more of the phosphate glucose inside the intracellular fluid. So when there's more phosphate glucose inside the intracellular fluid, it can attract now the potassium ion inside the intracellular fluid. That is another method of hormone production. And we said the second was insulin. Insulin was attracting because it causes the stimulation of glucose uptake and protein synthesis. Is it clear? Because those protein synthesis are going to attract potassium into the cells. Now the next one is sodium ion potassium ion homeostasis compared. Now we need to know that the ability of sodium ion is superior to that of potassium ion, whereas daily sodium ion loss can be reduced by less than 5 millimoles per day. Urinary potassium excretion cannot decrease below 20 millimoles per day. You need to know that what? Those people again saying that salt is not good, you need to know that the amount of sodium that can be lost per day is about 5. We have seen in the initial tutorial that there was 10 millimoles per day, but it can be reduced to 5 millimoles per day. But they need to know that what? Potassium is extremely needed, because potassium is going to be released at the amount of 20 millimoles per day. 20 millimoles per day of potassium is going to be released. So it's, again, with the fact of salt, it is not good to completely say that the patient should not take salt directly. Is it clear? It is, you should not sustain absolutely salt from the diet of a patient, because when you sustain absolutely salt, you don't have these ions that are going to stay in the body. Is it clear? There's going to be 20 millimoles per day that is going to be secreted from potassium, and sodium is going to be 5 millimoles. That's the first comparison. Since the normal GIT potassium losses amount of 20 millimoles per day, the daily potassium intake must be greater than 40 millimoles per day. Is it clear? In order for you to have that balance. Now, however, since the GIT secretion is rich in potassium, GIT fluid losses can rapidly lead to a negative potassium imbalance in a patient. So every time you have a patient have vomiting, because potassium is highly secreted in GIT compared to the other parts. The urine does not even secrete potassium, just like the GIT. So GIT likes secreting potassium. So when you have vomiting, you have diarrhea, you have GI fistula, just know that the potassium is going to be excreted as a major product from the GIT. Then the next one that is going to be excreted now is going to be sodium, depending on the different product. Now, hypokalemia. Now let's visualize hypokalemia. We need to know that what hypokalemia is a common and a potentially serious metabolic disturbance in general clinical practice. Is it clear? Now, what are the clinical features of hypokalemia? We start with cardiac arrhythmia. Cardiac arrhythmia can be induced by hypokalemia and often heralded by an ECG. Is it clear? So when you want to see that, you visualize an ECG. So here on cardiac, when you have hypokalemia, you're going to have an increased PR interval. So that's the first thing in hypokalemia. You're going to have an increased PR interval. The increased PR interval just tell you that what atrial repolarization has increased. Increased PR interval just tell you that there is an increase in the time of atrial depolarization. Is it clear? So that's why they say slowed atrioventricular conduction. The conduction between the atrium to the ventricle is slowed away. So that's why there is the PR interval, that increase in the PR interval. You have flattening, because you need to know that one hypokalemia is going to result to what? It's going to result to a state, because it's going to be low inside the extracellular fluid. It's going to result in a state of very low resting membrane potential. So the cells are going to be unexcitable or hypoexcitable. Is it clear? Since the cells are hypoexcitable, it means that what you're going to have is going to delay in the conduction time from the atrium to the ventricle. That's why you have an increase, a prolonged PR interval. Is it clear? Or you have a flattened and inverted T wave. Is it clear? So you have a flattened and inverted T wave, just to tell you that what repolarization is also prolonged. Is it clear? And it is not done with a very high acute or vigorous value. So you have a delayed repolarization because of inverted T wave, and you have flattened T wave. Everything is just prolonged here. So now, and the next again is that you can have also a prolonged QT interval in the case of a hypokalemia, because QT interval is just to tell you the time of depolarization is going to take also time to depolarize and also take time to repolarize. Is it clear? So all that is going to occur in the case of a beginning of a cardiac arrhythmia. Now, since digitalis, that's a drug that is frequently prescribed in cardiac failure, impairs the sodium ion potassium ATP, is going to aggravate the hypokalemia induced arrhythmia. Is it clear? So digitalis is one of the drugs that aggravates the hypokalemia. Why? Because you need to know that what digitalis is going to inhibit the sodium ion ATPase. So that's the first case. The next case is on muscle weakness. Now we need to know that what we said that hypokalemia is going to cause what? Is going to cause hypokalemia is going to cause hypoexcitation of the cells It causes hypoexcitation of the cells just because hypokalemia causes hypoexcitation of the cells just because of the fact that we have it causes hypoexcitation of the cell just because of the fact that we have low level of potassium ion outside the cell. Since you have low level of potassium ion, the resting immune potential is going to be extremely low. So since the resting immune potential is extremely low, there is a very high difference with the threshold voltage. You have hypoexcitation. So since you have hypoexcitation, you're going to have muscle weakness. Is it clear? Mimicking a pseudo paralysis. Is it clear? So that's another symptom that you have in hypokalemia. Now you have GIT, smooth muscle weakness, because of still hypoexcitation of the cells. Since you have still hypoexcitation of the cells, you are going to have GI smooth muscle weakness, such as constipation, progressive paralytic IVs. Now the next, you have polyuria and dehydration. Every time you have hypokalemia, you need to know that what the potassium ion is required for salt and water reabsorption. Is it clear? You need to know that potassium ion is required at the level of the sodium ion, potassium ion, this for the salt to be and water reabsorption, and also the potassium ion is required for sodium ion to be absorbed at the level of the distal convoluted tubules. Since potassium ion is not going to be there, you are going to have polyuria and also have dehydration in the case of hypokalemia. The next, we have glucose intolerance. You need to know that what potassium ion is required for insulin to act. Is it clear? For glucose to enter the cells. Is it clear? So every time that potassium ion is going to be absent, you're going to have excessive glucose level in blood. Is it clear? Now the next are the causes of hypokalemia. So what are the causes of hypokalemia? Now, causes of hypokalemia is when you want to visualize the potassium ion problem disorders, hypokalemia and hyperkalemia, you have to divide that into three. The first one is going to be based on decreased intake, decreased production or decreased intake of potassium ion. The second is going to be the redistribution of the potassium ion, and the next is going to be increased secretion of the potassium ion. All that are going to be based on the causes of potassium ion. So we start with the decreased intake of the potassium ion. You need to know that what in diet like food, fruits, meals, when you have decrease or you have starvation like anorexia nervosa, is going to result to a hypokalemia. Is it clear? Another form of decreased intake is going to be via alcoholism. Alcoholism is also going to reduce the potassium ion intake. Is it clear? You have parenteral nutrition without potassium ion supplementation, also going to reduce the potassium ion intake. So those are the causes there. Now the next cause is going to be renal losses, different losses. You need to know that potassium ion can be lost via the kidney. You have renal losses. Renal losses can occur via diuretics. Is it clear? So when you use diuretics which are not potassium ion sparing, you're going to have excessive loss of potassium ion, which is going to result to hypokalemia. So is it clear? So any diuretic that is going to impair the tubular sodium ion reabsorption is going to every diuretic that impair the tubular sodium ion reabsorption is going to affect the potassium ion. Is it clear? If you impair tubular sodium ion reabsorption, you are going to affect the potassium ion, because you need to know that what you need to know that every time you impair the tubular sodium ion reabsorption, you are going to reduce the sodium ion in blood, and then you reduce the osmolarity of blood, which is going to reduce the renal perfusion, and that's going to cause a physiologic activation of the aldosterone. And when aldosterone is going to be activated, it's going to cause the exchange of sodium ion at the level of the distal convoluted tubules with potassium ion. So every time you take diuretic that is going to impair sodium ion, there must be the loss of potassium ion. Is it clear? So even that amiloride, I just did a mistake. That amiloride that was impairing the sodium ion release is going to also affect that case. Now, so diuretics such as thiazide, loop diuretics, which affect the sodium ion release, we have it. So now the next one, we have mineralocorticoid excess, like in the aldosterone secretion in secondary or primary hyperaldosteroneism, is also going to result to excess to that. We can also have the case of excess corticosteroids, like in the case of Cushing syndrome. That's also going to result to a hypokalemia. Is it clear? Now the next is going to be a renal tubular acidosis. Is it clear? We said that in a renal tubular acidosis, you have inability of distal convoluted tubule to secrete hydrogen ion. Is it clear? Since there is inability of distal convoluted tubules to secrete hydrogen ion, and you need to know that what at the level of hydrogen ion, sodium ion is going to be reabsorbed at the expense of hydrogen ion and potassium ion. So potassium ion is going to be lost, and hydrogen is supposed to be lost. So if the patient suffers already from renal tubular acidosis type 1, it means that what? It means that it cannot secrete hydrogen ion. Since it cannot secrete hydrogen ion, potassium ion is going to be secreted more for sodium ion to be reabsorbed. Is it clear? So for sodium ion to be reabsorbed, potassium ion is going to be secreted more. Is it clear? And that's going to result to hypokalemia. Now, in the case of a type 2 renal tubular acidosis, where you don't have reabsorption of hydrogen carbonate from the proximal convoluted tubule, you are going to have excess of sodium ion is going to be delivered at the distal convoluted tubules, allowing the sodium ion exchange to occur. Is it clear? So here we don't have the reabsorption of the hydrogen carbonate. So sodium ion is going to stay with the hydrogen carbon at the level of the filtrate. So there's going to be excess of the distribution of the transfer of sodium ion to the distal convoluted tubules. Now the next we have the diuretic phase of acute renal failure. Is the next. Is it clear? So we have the diuretic phase of acute renal failure can result to hypokalemia, because you need to know, we have already said that acute renal failure have three phases. The first phase is uric, the second phase is the polyuric or diuretic phase. So in the diuretic phase, you don't have any reabsorption, the tubular function is lost. Is it clear? So it means that most of the ions, especially the potassium, is going to be lost. So you are going to suffer from hypokalemia. You can lose even 10 to 15 liters of urine per day. So this patient needs to be extremely rehydrated. Now the next disease is going to be Bartter syndrome, and we said that there's a difference between Bartter syndrome and Gitelman syndrome. All of them were having a hypokalemic alkalosis, where you have the loss. In Bartter syndrome, you have the defect of the sodium ion, potassium ion, chloride ion transporter. Is it clear? So you are going to have hypokalemia, hyponatremia, hypochloremia, and you also have, in addition to all that you have in Bartter syndrome, you have hypocalcemia, because there is hypercalciuria in this case. Is it clear? But now, in case of Gitelman syndrome, you don't have hypocalcemia, but you have hypomagnesemia, because you have hypermagnesuria in that case. Is it clear? So that is a clear. The next one, you have magnesium deficiency. You need to know that what every time there is magnesium deficiency, magnesium causes the secondary renal potassium leak. So every time there is a magnesium deficiency, potassium is going to be deficient. Is it clear? Now we can have other losses again, which is gastrointestinal potassium loss. You need to know the gastrointestinal system can lose easily potassium. This is potassium ion. So in cases like diarrhea, you can have hypokalemia. In cases like enteric fistula, you can have hypokalemia. In cases like vomiting, hypokalemia. In cases like, but in the case of vomiting, you lose both the potassium ion and hydrogen ion. So it's a hypokalemic alkalosis. So in case of villous adenoma of the rectum, you have hypokalemia. Now, what is now in the case of redistribution, when there is a movement of potassium ion from the intracellular fluid to extracellular fluid, what can cause this? If you have acute alkalosis, is it clear? So if you have acute alkalosis, diabetic acidosis, which is being treated with insulin, is it clear? So like in case of acute alkalosis, when you have alkalosis that has occurred very fast, it means that there is excessive high level of hydrogen carbonate in blood which has occurred very fast. There is going to be a redistribution. Is it clear? Acute alkalosis is one. Second is diabetic acidosis, which is being treated with insulin. You need to know that what diabetic acidosis, when you have diabetic acidosis, which is treated with insulin, can also have a redistribution where the hydrogen potassium ion is going to move from the circulation out into the intracellular fluid. So here you are going to just try to these are the cases of hypokalemia. Is it clear? So in the case of diabetic acidosis treated with insulin, you need to know that what insulin causes potassium ion to enter the cell. So you are going to have a shift of fluid from the extracellular fluid to intracellular fluid. When we say hypokalemia, it means that there is low level of potassium ion in plasma, and plasma is among the extracellular fluid. And in redistribution, you have potassium ion moving from extracellular fluid to intracellular fluid. Is it clear? Like the usage of insulin in patients with diabetic ketoacidosis. You have also the uses of, in the case of acute alkalosis, as I've already told you, every time you have alkalosis, you have hypokalemia, but when you have acidosis, you are going to have hyperkalemia. So, but hydrogen ion like to work with the potassium ion, except at the level of the kidney where they can go in opposite direction. But in the blood and other cells of the body, that is the typical theory that you have to retain. Now, the next is the beta adrenergic drugs. Is it clear? For the beta adrenergic drugs, as you already said, all the beta adrenergic drugs with catecholamines are going to cause what? They are going to cause the glycogenolysis and the production of the phosphate glucose at the level of the intracellular fluid. That is going to cause a reabsorption now of potassium ion from extracellular fluid to intracellular fluid, resulting to hypokalemia. So how do you treat hypokalemia? To treat hypokalemia, you must, the plasma potassium ion reflects the whole body potassium ion content. Generally, the plasma potassium ion is going to reflect the whole body potassium ion content, and reasonably well, but can occasionally be misleading in cases of patients with diabetic ketoacidosis. In patients with diabetic ketoacidosis, when you give them insulin, you think that this patient don't have enough potassium ion all through the body, but when you give them insulin, the potassium ion is stored inside the intracellular fluid. Is it clear? Also, when you give patient beta adrenergics, the potassium is going to be stored inside the intracellular fluid. When the patient has alkalosis, acute alkalosis, the potassium is going to be stored inside the intracellular fluid. So in this patient, you have to add potassium ion with care. So you don't give just potassium ion anyhow. In this patient, you have to add potassium ion with care. So hyperkalemia may be present despite the profound intracellular potassium ion depletion. A problem in correcting the large deficit of intracellular potassium ion is the relatively small extracellular fluid through such potassium ion replacement. Is it clear? So you are going to try to increase the value of potassium ion in the extracellular fluid. Is it clear? Give the patient potassium ion, so rise than, so, and you give potassium ion and such that it should not rise more than 60 milliequivalent per liter. Is it clear? So you can replace the potassium ion via infusions, you can replace via orally and all that. Is it clear? Now the next one is that what? So you need to know that potassium ion should never be administered undiluted. Is it clear? In fact, injection of the concentrated potassium ion should, the standard method, should never be done. Is it clear? So every time you give a patient potassium ion undiluted, just know that the patient is going to die in few seconds. Every time you want to give patients on the potassium ion, you must always dilute potassium ion in a certain solution. You never give potassium ion undiluted, else the patient is going to have hyperkalemia, and then that's certain death. Now, the next is hyperkalemia. So what are the causes of hyperkalemia? This can be divided into excess intake, impaired renal excretion, and redistribution. Still now from the intracellular to extracellular fluid. Now in the case of hyperkalemia. Now in case of excess intake, you have excess intake from the diet, that can result to that. So you can have also, a case of hyperkalemia can occur when you have a renal failure, where there is impairment of the kidney from, so in the case of oligoid phase of the renal failure, or you can have a patient with chronic renal failure. Is it clear? So they cannot actually filtrate well potassium ion, they can have hyperkalemia. Now the next one, or you can have in the case of blood transfusion, it can also result to hyperkalemia. Now the next is decreased renal excretion. In decreased renal excretion, you have things like, so the first one was increased intake like transfusion, like in the use of potassium sparing diuretics, like in the use of different that. Now we have decreased renal potassium intake. The decreased renal potassium intake, you have acute renal failure. Is it clear? Renal excretion. Acute renal failure is going to cause increased potassium ion, like hyperkalemia in the oligoid phase, because there is no filtration. Is it clear? The second is going to be certain drugs like potassium ion sparing diuretics like spironolactone or amiloride. Is it clear? Spironolactone, amiloride are going to be potassium ion sparing diuretics. I said initially that the amiloride is going to act at the sodium ion channel at the distal convoluted tubules to prevent the sodium ion to be high. They act on sodium ion channel at distal convoluted tubules, so they prevent the degradation of sodium ion at the level of the distal convoluted tubules, such that you don't have the excretion of the potassium ion at the distal convoluted tubules. Is it clear? And also we have spironolactone. So amiloride is not an anti-aldosterone, so the mode of action is actually different. Now the next one, you have adrenal insufficiency also. So in adrenal insufficiency, whether congenital or not, like congenital as in the case of a 21 hydroxylase deficiency, is it clear, which or acquired in the case of Addison's disease. So when you have adrenal insufficiency, in these cases you are not going to have enough production of in 21 hydroxylase, you don't going to have enough production of aldosterone. Is it clear? So when aldosterone is not going to be produced, you are going to have a salt losing state. Is it clear? You have a salt losing state, and then you have hyperkalemia. Low sodium iodine reabsorb potassium ion. The next one is a hyporeninemic hypoaldosteroneism. So in this case, you have a case where you have low level of renin. So it's a failure of renin secretion. Since you don't produce renin, you're not going to have aldosterone in blood. Now the next is the movement of potassium ion from the intracellular fluid to the extracellular fluid in the case of a redistribution. Is it clear? So the redistribution can occur in case of acute tissue injury. So if you have acute tissue injury, like in the case of rhabdomyolysis, means that the muscle cells have been destroyed, or you have in the case of a malignancy, where you do radiotherapy to kill many malignancy, you can also liberate the potassium ion from the cells. Is it clear? So you have crush injury from muscles. Is it clear? Acute hemolysis, all that, even radiotherapy, everything that can kill cells can also aggravate the hyperkalemic state. The next one is acidosis. Acidosis is going to displace the potassium ion. As I've already said, every time there's hydrogen in blood, potassium is going to follow, but that action is going to be contrary at the level of the kidney. So may be contrary at the level of the kidney. Now the next one is depolarization, depolarizing muscle relaxant. Is it clear? So there's also certain muscle relaxant that can also cause that redistribution. So when you have the muscle relaxant such as succinylcholine, it can cause the transient hyperkalemia by preventing potassium ion reuptake from accurately depolarized muscle. Is it clear? So now the next form of hyperkalemia is called a spurious hyperkalemia. So this refer to reporting hyperkalemia in a patient in whom the circulating potassium ion is in fact normal. Is it clear? So you have what is called spurious hyperkalemia, where there is hyperkalemia in patient in whom the circulating potassium is normal. It has a variety of causes. Is it clear? So the circulating potassium ion concentration is normal, but there is reported hyperkalemia. Now, here, what are the causes of spurious hyperkalemia? You can have release from the red blood cell during or after venipuncture. When you do a venipuncture, you can have a spurious hyperkalemia, but the level of the potassium ion in the circulation is normal. So you can have a release from red blood cell during a venipuncture. When you have hemolysis, so when you do a venipuncture, you can have hemolysis, which can result to the loss of potassium ion from the red blood cells, and which causes an acute increase in the potassium ion level. Drip arm contamination is described as a situation whereby blood sample from one side is contaminated with fluid infused in the nearby site. Is it clear? So you have cubital fossa and the back of the hand respectively. Now you have also the release of potassium ion from the white blood cell and the patient. In patients who are particularly high in white and platelet counts, is it clear? So they are going to have some forms of hyperkalemia, but actually when you measure the level of potassium is normal. Now you need to know that hyperkalemia has a very detrimental effect on the heart. So you need to know the effect of hyperkalemia on the heart. Is it clear? Hyperkalemia can kill without warning. In hypokalemia, you have warning sign because it's going to cause bradycardia, then it's going to cause decreased oxygen potential before you have ventricular tachycardia and ventricular fibrillation later. It's going to occur very later. But now in hyperkalemia, it's brutal because in hyperkalemia, it is going to cause an excessive excitation of the heart in this case, unlike in hypokalemia where it causes decreased excitation. Between decreased excitation and excessive excitation, what can kill more the heart is excessive excitation. Is it clear? So effects of hyperkalemia on the heart. So hyperkalemia can kill without warning. It's lower the resting membrane potential. Is it clear? It's going to lower the resting membrane potential and increase the rate of repolarization and predisposes ventricular arrhythmia. So lowering means that what? It means that it is going to, the resting membrane potential is going to be above the threshold voltage. Since there is more potassium ion outside, you just use the voltage, potassium ion in, all over potassium ion outside. You see that ratio is going to be smaller. Since the ratio is going to be smaller, it means that the cell is going to be more excitable. So the cardiac arrest in due to ventricular fibrillation may be the first sign. ECG characteristic, you have things like the peak T wave. So peak T wave is just to tell you that what there is excessive repolarization that is occurring. Is it clear? So repolarization is occurring in an excessive state. You have absent P wave is another problem. You have widening of the QRS complex. The QRS complex is going to widen, is it clear, and provide early signs. So all those are early signs of hyperkalemia. So you see at the beginning, this is the QRS complex here, which has been widened. So you can see even the QR. So it's no more a QRS. You see a QR complex. You see a low SC segment, prominent U wave can show that. Now you have the QRS also here. T. So after that, you are going to have a sinusoidal waveform. So you are going to have peak T wave has been shown because there's going to be excessive repolarization. In hyperkalemia, when you have excessive potassium, you are going to have excessive repolarization. Is it clear? So so here you are going to have a sinusoidal wave at the end with peak T wave, a broad QRS complex, an SC segment depression, and an absent P wave. So that is going to be what occurs at the end of the phase. So the management of hyperkalemia. For mild hyperkalemia, you need to limit the potassium ion intake. Just limit the potassium ion intake. Is it clear? But in other cases of hyperkalemia, like so we have so other cases of approaches to treat hyperkalemia, you can use insulin and glucose infusion because insulin is going to cause glucose to enter the cell, and with potassium, that's going to reduce the potassium ion level. But in this case, you are not secreting the potassium ion out of the circulation. You are increasing, you are just redistributing the potassium ion. So in this case, you have to take care. The patient will not have hyperkalemia, but he has excess of the potassium ion inside the intracellular space. Is it clear? So now the next one is the sodium chloride infusion with diuretics. You can use sodium chloride to this patient and give diuretics such that the patient can excrete the potassium. Now the next one, you can use sodium hydrogen carbonate infusion. Sodium carbonate infusion is used when you have a hyperkalemia in case of acidosis. You give sodium hydrogen carbonate if you think that the patient has a hyperkalemia with acidosis, such that you can induce an alkalosis that is going to reduce the potassium ion in blood. Now dialysis is the last method of resort, and it is used when the plasma hydrogen, the potassium ion level is going to be greater than 7 millimolar per milliequivalent per liter. Is it clear? And you use it in a case where you have a patient with acute renal failure or in a patient with chronic renal failure. Is it clear? That's when you use dialysis. It can be hemodialysis or peritoneal dialysis. Now, in an acute situation with imminent cardiac arrest, so you have IV fluid infusion, calcium gluconate. So you can also use calcium gluconate, which can also be used to protect against hyperkalemia by antagonizing the effect of cardiac excitability. Is it clear? So you want to do that. Now, so from here we are finished with everything involved with the potassium homeostasis. And we say thanks for your kind attention. Please don't forget to like and subscribe for our channel. Thanks very much.